Hello, my name is Lynn McClure. Welcome to my Doctorate of Nursing Practice Research Project presentation on medical cannabis for fibromyalgia. Here are my DNP Project Committee members, Dr. Gordon West as my DNP Chair, Dr. Bolad is the Clinical Site CEO, and Dr. Singh is a community person. In looking at the phenomenon of interest, as a nurse practitioner, I had previous experience that inspired me to conduct the DNP project on medical cannabis for fibromyalgia. I worked in the pain management clinic with an atypical role. I assisted a medical doctor in transitioning patients with chronic pain who were on multiple narcotic medications to slowly incorporate medical cannabis with close regimen recommendations from the medical doctor, along with other therapies such as medication-assisted therapy and cognitive behavioral therapy. I had watched various patients successfully wean off their many narcotic drugs with the use of medical cannabis. This inspired me to learn about the alternative plant-based treatment of medical cannabis with as many benefits, uses, and formats as part of holistic complementary practice for patients with chronic pain. Fast forward to a later time, I worked in a rheumatology clinic where I experienced patients with autoimmune rheumatic disorders, often comorbid with a debilitating condition known as fibromyalgia. These conditions had the same corresponding problem that the patients in the pain clinic had. These concerns involved chronic pain. However, fibromyalgia had a slew more symptoms necessitating more than just pain medications, but other drugs to treat the other various symptoms of fibromyalgia. Fibromyalgia is characterized by chronic generalized diffuse widespread musculoskeletal amplified pain in the joints and muscles, often associated with other symptoms of fatigue, brain fog, headaches, leading to migraine, sleeping disturbance, leading to insomnia, gastrointestinal disturbance, and anxiety or depression. Chronic pain is their primary ailment. Fibromyalgia has a 3-to-1 female to male occurrence with a prevalence of at least 7% of the general U.S. population. Patients in the rheumatology population with rheumatic disorders, comorbid fibro, are managed with at least 5 multiple prescription medications, leading to a negative outcome of polypharmacy, found to be highly concerning, stemming from the standard of care. The current practice in managing fibromyalgia often involves treating the multiple symptoms individually. As mentioned earlier, fibromyalgia manifests more than 5 symptoms, resulting in more than 5 medications, each trying to manage each symptom. This is known as polypharmacy, which is a problem for many patients. Polypharmacy leads to adverse reactions, more drug-to-drug interactions, and negative patient outcomes. Other issues involve increased healthcare costs, more different specialties involved, such as pain management, psychiatrists, gastroenterologists, neurologists, more patient return visits, urgent care visits, and emergency visits, as some drugs, such as opioid overdose, can lead to detrimental life-threatening problems. In rheumatology, the main focus is treating rheumatologic autoimmune disorders with their primary disease, modifying anti-rheumatic drugs known as DMARDs, such as methotrexate, leflunomide, Plaquenil, or sulfasalazine. Sometimes there are additional biological medications from TNF inhibitors like Enbrel or Humira, IL-1, IL-17, JAK inhibitors, other drugs targeting specific pathways. DMARDs and biologicals come with severe and common side effects that may involve immunosuppression, risk for infections, hepatotoxicity, nephrotoxicity, and myelosuppression. So let's think about how these drugs are already on a patient's medication list, let alone any other drugs that the patient may have for other disorders from other specialties or primary care. Now add on the medical condition of fibromyalgia, and that list of prescription drugs becomes much longer. Now let's look further in detail at how polypharmacy becomes a problem when fibromyalgia is managed with treating each symptom individually. Non-steroidal anti-inflammatory NSAIDs like meloxicam and diclofenac have serious side effects of nephrotoxicity, gastritis, peptic ulcers, and hepatotoxicity. Steroids include prednisone or methylprednisolone. It has common side effects involving elevation in glucose, bone density loss, cardiovascular risk, elevated blood pressure, irritability, and weight gain. Antidepressants such as Cymbalta and Savella, indicated for fibromyalgia, can cause an increase in suicidality like other antidepressants. Anticonvulsants such as gabapentin and Lyrica and muscle relaxers like baclofen and Flexeril carry side effects of somnolence, impaired coordination, and drowsiness. Sleep aids such as trazodone or Ambien can affect elderly patients with addictive behavior or can lead to a possible imbalance in coordination from somnolence with the addition of other medications. Migraine medications such as Fibrosec can carry hepatotoxicity and withdrawal risks. Medications for gastrointestinal symptoms, even as needed, for example, Zofran or dicyclomine, may have interactions with other drugs. Narcotic drugs like oxycodone, morphine, they all have serious adverse effects of addiction, withdrawal symptoms, respiratory depression, and a high risk for cardiac arrest. The problem, intervention, comparison, outcome, and time frame, or PICO, were considered when addressing the DMP research project situational purpose and goals. The PICO inquiry for this DMP project was in adult patients with fibromyalgia who are on polypharmacy regimen to manage symptoms. Does the implementation of an educational intervention for practitioners and patients about medical cannabis as an alternative or adjunct treatment compared to the standard practice of prescribing multiple medications increase the number of MC referrals post-intervention during a 6 months time frame? Ultimately, the DMP project's purpose is to improve patient outcomes in the fibromyalgia population. A cognitive theory of multimedia learning as a framework was used to implement the DMP project's intervention. An informative MC educational poster linked to a YouTube video about MC was created and approved by the clinical site's Chief Executive Officer, or CEO, to educate practitioners and patients indirectly. The intervention included, as mentioned, an appealing poster with a two-dimensional QR code leading to a YouTube video provided to practitioners and patients about the benefits of MC for fibromyalgia from evidence-based literature and other accredited educational videos about medical cannabis. The interventional framework also provided references on safe clinical guidelines to prevent concerning issues such as substance use disorders. The DMP's overall goal from increasing knowledge of the benefits of MC for fibromyalgia is to indirectly reduce the problem of polypharmacy found in patients with fibromyalgia. The DMP research project was a qualitative observational project to increase MC referrals by improving practitioners and patients' confidence in MC to manage fibromyalgia symptoms. The expected outcome of the qualitative observational study would be an increase in the number of MC referrals by practitioners for patients with fibromyalgia as one of the initial therapies over standard care of prescribing multiple medications. This project required electronic medical records, informatics, and technology to account for the MC referrals at the end of each clinical day to be totaled for the 6 months of retrospective data with 3 months of pre-intervention data and 3 months of post-intervention data. A pre- and post-questionnaire survey was initially planned for practitioners at the rheumatology clinic before and after the MC educational video and post-intervention phase. It was intended to compare the practitioner's pre- and post-intervention knowledge levels regarding the benefits and safe practices of MC therapy for fibromyalgia. However, this did not occur after the Maryville Institution Review Board, or IRB, approved an amendment to eliminate the pre- and post-questionnaire survey for practitioners. Measurable data was collected by counting the number of MC referrals made by practitioners before and after the interventional session. The project was completed in approximately 26 weeks. Research has shown that MC not only improves chronic pain and fibromyalgia, but also reduces polypharmacy, leading to less detrimental life-threatening side effects compared to the drugs detailed earlier. MC's use, safety, and efficacy for fibromyalgia are much less complicated. MC has been indicated for the use of chronic pain syndromes, anxiety, post-traumatic stress, sleeping disorders, seizures, and depression. Side effects of MC can cause a high sensation if not used medicinally. If not used appropriately or medicinally, such as recreational marijuana, which often gets misused, can cause worsening brain fog and enhance anxiety if using products higher in chemicals of delta-9 tetrahydrocannabinol or THC than cannabidiol or CBD ratio. There are many different forms of MC. These include creams, capsules, tinctures, edibles, vates, and oral sprays. Literature also shows that when MC is used medicinally under safe clinical practice guidelines, substance use disorder with MC is preventable. Overall, a vast amount of literature supports the DMP project's goals, purpose, and aims. Moving into how the DMP project's evaluation methodology started with the data collection sheets. The data collection sheets contained de-identified information after inclusion and exclusion criteria were met concerning the subjects, which were essentially the EMR charts. Data was collected on whether referrals was written for patients with fibromyalgia to get an evaluation for MC. Other information on the gender and age group concerning the MC referral was also obtained. Only the minimum data necessary to accomplish the goals of the DMP project as coded were recorded. These instruments were utilized for data analysis to review the effectiveness and outcome of the quality improvement intervention. The data collection sheets were simple tables that showed the for coded data. It allowed for coded data. There are described nominally to infer pre and post intervention, where 1 equals yes and 2 equals no, whether written MC referral was made for the patient with fibromyalgia. Furthermore, the coded data of 1 equals male, 2 equals female, and 3 equals other infers which gender received MC referrals, while 1 equals 18 to 30, 2 equals 31 to 50, 3 equals 51 to 65, and 4 equals 66 to 89 infers to which age group. Other sources were considered instrumental tools during the implementation of the DMP project. One of the tools is the medical cannabis guidelines established by the Americans for Safe Access. The other instrument used in the DMP project was the Cannabis Essentials Tools for Clinical Practice by the American Academy of Family Physicians. They were both utilized with other evidence-based literature to create the DMP Quality Improvement Educational Framework. These instruments had great validity and reliability. They contained truthful, published evidence-based research with informative data as resources established by reputable organizations. From the literature review, no standardized educational framework on MC benefits for fibromyalgia was identified. The quality improvement intervention was created as part of this DMP project. It comprised evidence-based literature supporting the multiple benefits of MC for fibromyalgia using safe current practice guidelines. The program was approved by the clinical site CEO and was presented to patients and healthcare practitioners in the rheumatology clinic. The intervention was presented on an appealing poster in every patient exam room with a QR code to a visual, auditory, and entertaining video that had other accredited embedded videos. This helped initiate attention, increased knowledge, and reinforced information on the subject. The DMP project is a quantitative exploratory design comparing medical cannabis referral rates pre and post intervention. The sample consisted of 154 EMRs of de-identified adult patients diagnosed with fibromyalgia at the rheumatology clinic between January 1st and June 30th of 2024. The EMRs were divided into two groups based on the pre and post implementation. The educational intervention on medical cannabis benefits for fibromyalgia was implemented on April 2nd, 2024. The pre-intervention group consisted of retrospective review of 77 EMRs of fibromyalgia patients during 3 months from January 1st through March 31st, 2024. The post-intervention group consisted of 77 EMRs of fibromyalgia patients during another 3 months from April 3rd through June 30th, 2024. The evaluation of the educational intervention framework on MC benefits for fibromyalgia was completed using data collected from the retrospective EMR review of the samples to compare the rates of proportions of MC referrals for fibromyalgia patients pre and post intervention. The data collected to evaluate the effectiveness of the educational intervention based on the rates of MC referrals written pre and post intervention were utilized and analyzed using the upper tail z-test for the difference of two proportions as a directional form of the chi-square test, with a significant effect size of 0.05. The statistical significance analysis results are shown in the following slides, which helps determine whether the DMP project's intervention was effective. Getting into the results, the following are data representations for descriptive statistics in the form of graphical pie charts. Here in Figure 1 is a pre-intervention sample of 5% that got MC referrals, while 95% did not. The post-intervention sample of 17% got MC referrals, while 83% did not. Here in Figure 2, the pre-intervention sample consists of 97% female patients, 3% male patients, and 0% other gender patients who received MC referrals. In comparison, the post-intervention sample consisted of 94% female patients, 6% male patients, and 0% other gender patients who received MC referrals. In Figure 3, the age intervals of the sample from pre-intervention group included 3% ages 18 to 30, 36% ages 31 to 50, 47% ages 51 to 65, and 14% ages 66 to 89 that received MC referrals. The age intervals of the sample from the post-intervention group included 4% ages 18 to 30, 41% ages 31 to 50, 43% ages 51 to 65, and 12% ages 66 to 89 received MC referrals. Microsoft Excel and the Statistical Package for Social Sciences, SPSS, were used with an alpha of 0.05 as the significance criteria to analyze the data on the MC referral rates pre and post intervention of the DMP project to conclude the effectiveness of the educational intervention framework. As a directional form of the chi-square test, the upper tail z-test was used to analyze the difference of two proportions to assess the MC referral rates pre and post intervention. However, let's focus more on the pertinent results of this data analysis from the SPSS. From the previous table as highlighted, the upper tail z-test indicated that difference in the MC referral rates between the pre and post intervention groups was statistically different, with a z-score of 2.3143 and a p-value of 0.0103. The p-value of 0.0103 is less than the significant level of 0.05, which shows sufficient information to suggest an increase in the proportion or ratio from pre to post intervention. The confidence interval indicates the actual change in ratio from pre to post intervention. Since 0 is not included in the interval, significant evidence shows its shift in one direction. Based on the achieved power of the project, which was calculated at 0.7522, the DMP project's power was considered medium to high in strength. It was concluded that the educational intervention framework of a poster with a QR code to a video on the benefits of MC for fibro, without any noted barriers, successfully increased the rate of MC referrals. The framework provided consistency in the implementation process, increasing the MC referral rate as compared to between pre and post intervention. Here we apply the results of the DMP projects to the clinical significance. MC referrals were higher in the post-intervention than in the pre-intervention group. MC referrals were higher for females and males pre and post-intervention, with the other group showing no referrals. So 31 to 50 and 51 to 65 age intervals had higher rates of MC referrals than the 18 to 30 and 66 to 89 in both pre and post-intervention groups. While these demographic trends did not directly correlate with the intervention's effectiveness, they provide valuable insights for future studies. The data on MC referral rates pre and post-intervention was essential for the goals of this DMP project. The intervention framework successfully improved the number of MC referrals from the pre to post-intervention. The framework addressed the concerns of polypharmacy in fibromyalgia patients and the lack of alternative therapy education on MC benefits for patients with fibro. The SPSS and Excel results and the outcomes analysis showed a statistical significance with an increase in the rates of MC referrals from pre to post-intervention. The DNP project facilitators involved a good collaboration among the researcher, clinic CEO, DNP chair, faculty, and committee member. Fortunately, there were no barriers to the project. Although the DMP project provided clinical significance, there were unintended consequences. These unexpected consequences involved the researcher having to amend the initial Emeryville University IRB application in February 2024 to no longer include the pre and post questionnaire surveys on rheumatology practitioners' knowledge about MC for fibromyalgia. This change was amended because the survey tool for the practitioners was inadequate and required many changes. The survey tool also did not meet the overall aim of the DMP project, which was to increase the rate of MC referrals. The amendment also had benefits, such as no engagement required of human subjects as the rheumatology practitioners. Other unintended consequences of this DMP project concerned ethical issues. There was a moral concern about the potential psychological effects of patients and providers' opinions of medical cannabis having a stigma. The stigma is often associated with the potential for medical cannabis to contribute to substance use disorder. The words consisting of marijuana or cannabis may be triggering to patients and practitioners that could potentiate an automatic dismissal of accepting any education on medical cannabis benefits. There were some limitations. From the implemented research project, more than 4 healthcare practitioners were needed in the rheumatology clinic to show an increase in MC referrals. By the time the project was implemented, or even during its implementation phase, there may have been a loss or gain in the number of practitioners, which may have affected the project's expected outcome negatively or positively, skewing the data. For example, the number of MC referrals before the educational interventions could have been lower because there were fewer practitioners compared to the future number of practitioners, since the rheumatology practice was continuously growing with the addition of practitioners. Other limitations involve patients declining MC due to cost, as insurance does not cover it. Whether practitioners are more knowledgeable in educating patients on the many benefits of MC, the expense of this alternative therapy could have deterred patients, leading to refusals of MC referrals. Some patients are not able to accept the MC referral simply because of personal reasons or their job restrictions or policies against any THC substance. There is some missing data concerning the errors in the electronic medical records, or EMRs, and gender assigned in the charts. The clinic EMRs did not have an option for other types of gender, but only female or male. Thus, the data for other genders is missing. This leaves missing data correlating MC referrals to other gender groups besides males or females. The only missing data would be no data concerning MC referrals for the other genders, since the EMRs did not have that option, which is out of the researcher's control. The potential for missing data could also contribute to the unintended consequences. The implications for advanced practice nurses, or APNs, is that it gave them more knowledge from an alternative holistic approach. Patients nowadays are looking toward plant-based supplements and want to steer away from multiple pharmacologic-driven drugs. They have realized the many side effects and complications caused by many medications. APNs need to be well-versed in alternative options such as MC. Having evidence-based knowledge that MC will benefit patients with chronic pain, mainly stemming from a condition of rheumatologic disorders and fibromyalgia, is invaluable. Patients trust their healthcare practitioners, and when educated and counseled by them about MC, there is less hesitancy and less stigma associated with medical cannabis when it is presented in medicinal layman's terms. The knowledge gap would be bridged by the APN's patients and other practitioners because of this DMP project. They would be equipped to counsel, educate, and advocate the benefits of medical cannabis for patients with chronic pain and secondary rheumatologic disorders with fibromyalgia who genuinely need it. The DMP project's findings established the importance of an educational framework with evidence-based information for rheumatology practitioners and patients with fibromyalgia on the benefits of MC for fibromyalgia. The goal of the intervention was met based on statistical results from the data collection that showed an increased rate of MC referrals post-intervention compared to pre-intervention. The project was strongly supported by statistical data indicating the effectiveness of the educational intervention, which supported the aims of the DMP project. This led to practitioners and patients considering the use of medical cannabis as an alternative therapy as opposed to drug prescriptions for the management of fibromyalgia. This in turn indirectly helped practitioners and patients with fibromyalgia to focus on reducing polypharmacy. The DMP project's statistical results revealed differences between the observed and expected outcomes. Before the implementation of the educational intervention framework on the benefits of MC for fibromyalgia was completed, the expected outcomes not only involved an increase in the number of MC referrals post-intervention compared to pre-intervention, but there was an expected outcome on the reduction of polypharmacy. However, the second expected outcome would require collecting data on the number of prescription drugs pre and post-intervention. The overall goal of reducing the problem of polypharmacy in the rheumatology clinic is an expected outcome, as an expected outcome could not be directly researched in the DMP project. The outcome goal of reducing polypharmacy was only an expected potential consequence of implementing the DMP project. To have statistical measurements of whether there was an actual reduction in polypharmacy post compared to pre-intervention as an expected outcome would require a separate research. This would have required longitudinal study of patients who have tried MC, which is suggested for future research studies. Recommendations for other future research using this DMP project same evaluation method can be used on the evidence-based benefits of different alternative therapies for fibromyalgia, such as cognitive behavioral therapy, CBT, or aquaphysical therapy, ABT. Further steps should be considered based on the DMP project's findings, which include incorporating evidence-based information on CBT and ABT, along with MC as part of the educational intervention framework, which will increase not only the MC referral rates, but perhaps also increase CBT and ABT referral rates post compared to pre-intervention. The DMP project would contribute to a generic concentration focusing on multiple alternative therapies for fibromyalgia instead of MC only. This will undoubtedly have a much more positive impact on the current practice of numerous drug prescriptions for patients with fibromyalgia by giving more education on multiple alternative options of CBT and ABT besides MC, potentially reducing the problem of polypharmacy. The implications of the DMP project could also be recommended for future research projects concerning the number of medications pre and post use of MC in patients with fibromyalgia. The DMP project will continually change the current practice of multiple drug prescriptions to manage the symptoms of fibromyalgia. By continuing to utilize and keep the educational intervention framework with the information poster leading to a video for reinforcement, practitioners and patients will be reminded of the evidence-based benefits of MC as an alternative therapy to drug prescriptions in managing fibromyalgia. Continuing the work of the DMP project in the future involves keeping the educational poster consistently displayed in the patient exam rooms with the approval of the clinic CEO. With previously discussed recommendations, ongoing editorial revisions to the poster and video will include evidence-based data on CBT and ABT for alternative conservative options with the MC therapy. This would keep the DMP project of interest continually going, as it can be repeated to implement the effectiveness of the interventions on CBT and ABT to increase referrals for fibromyalgia patients to these other therapies as well. As one can see, because the DMP project's intervention had great significance and effectiveness, it has sustainability, since it can be repeated for other similar interventional topics, such as CBT and ABT benefits for fibromyalgia. In summary, the DMP project on medical cannabis for fibromyalgia addressed the goals of indirectly reducing polypharmacy concerns in the patient population with fibromyalgia. The research methodology with statistical analysis showed that having an educational intervention framework through evidence-based literature had significant effectiveness, since the project revealed an increase in the number of medical cannabis referrals post compared to pre-intervention. Overall, the DMP project on medical cannabis for fibromyalgia, along with its interpretation, implications, conclusions, and recommendations for future research, has sustainability. Here are the references supporting this oral presentation on this DMP project. I thank you for listening to this DMP project presentation.